Oh, we're live.
Yeah,
Well,
they can hear us. They can't see us yet.
Oh, they can't see us yet. Okay.
Are we all set? Are we live?
Hey, we're live. Hey, good afternoon, everybody. You know, this continues to go forward. It gets worse as it goes. So now Doc doesn't have any facial hair. He had to shave. So
Terrible.
he keeps trying to wear a surgical mask so he doesn't look
Right.
bad.
You recognize me if I put
See?
it back on. So you know I look normal. Okay, so
Gets worse as we go. I'm wearing an EMS Academy shirt. He wouldn't let me put paramedic on it though.
never,
So
never. How are we looking, you guys? Do we have people joining us yet?
3 watching. Oh, as of 90 seconds.
Yeah. Let me see if we get a couple more people to come on here before we get started. I think.
We'll have to redo our joke material. That's all I had.
No, I think that was probably just fine.
Yeah. How long a notice did we give on this? 2 hours. Yeah. It's hard. And when people are running calls. Yeah. Well, after we wait, you know, a couple minutes.
There's a couple jumping on right now. It looks like so. That's right.
Sure. Why don't we just, we'll start over. And good afternoon, everybody. Glad to have quite a few people on. We're up to 30 now, so that's really good. It's Craig Hare, Director of the EMS and Fire Administration, and just wanting to check in and keep the information flowing because lots of things are changing very quickly. You can see it gets worse as we go. Dr. Jameson is now without any facial hair, and
It's terrible.
very
Absolutely
upset
terrible.
about it. He let me wear my EMS Academy shirt, but he wouldn't let me put paramedic or instructor on it. So we're doing our best here as we go along. So we've got a new medical control directive that's going to drop in a few minutes, and we wanted to walk you through that as kind of job one.
Yeah. Thanks. So, hey, good afternoon, everybody. Thanks for coming over and tuning in. What we're going to do is we're going to walk through the updates that are in the medical control directive for today, and then we'll take any questions that anybody wants to put up in the comments section. We will record this, right? And we will post it to Target Solutions as well for anybody that doesn't have an opportunity to watch it live. But if you are watching us live and you want to make sure your friends have the link so everybody can get their questions in, by all means, share with them. So with that, we'll go ahead and go through the Medical Control Directive. This is Medical Control Directive 2020-12. It is two parts. It's 12.1, which pertains to dispatch, and really doesn't change too much of what's happening at dispatch. And then 12.2, which are some updates for the field crews. Hey, can we put up that? Okay, it's up. Great. So you should be able to see it on your screen now, and we'll just walk you through. First is the that this information, this new information in this medical control directive supersedes the information in 2020-11, which was the last medical control directive.
Yeah. So one of the things that we want to do is take down all of the placards, take down all of your prior memos, and here is one set of guidance that we're giving you clean. And please, you've got to take the time to read it. I know we're type A personalities. Just tell me and we're going to go. But please take the time and read this. This is about your safety and patient safety. Make sure everybody's doing it, making sure that we're putting the placards up, making sure that we're getting everything else out of the way, because as this guidance change, we don't want somebody to be on the wrong version.
That's right. It's really important. This situation is evolving very, very quickly. We are in a position now that a couple days ago was hard to imagine, and a couple days before that, the same thing was true. I'll just give a couple brief updates about what the situation looks like today, what we can probably expect over the next couple days, and then we'll get right into the bottom line. What do you need to know to keep yourself safe out there? And so first I'll say is that at this point, as of this filming today, which is Thursday, March 19th, we are up to double-digit cases in Pinellas County. And cases exist both out there in the community as well as in our healthcare facilities. More than one of our hospitals has cases within the hospital right now, and I expect that very shortly all of our hospitals will be seeing cases if they haven't already. The case count you should know, because this is getting kind of sensationalized a little bit on the news right now with running tickers and everything like that. You should know that an epidemic curve is an exponential curve, which means it's not a straight line. It goes way up through the roof like that. And we expect that to be even more pronounced than normal over the next 4 to 5 days as the backlog of testing gets worked through, and as well as testing ramps up in the community. So as the amount of testing goes up very quickly over the next few days to week, the case counts will be rising even faster than they normally would in an epidemic. So expect to see large numbers of increased cases over the next week. That should not be a surprise.
So that case doubling is about every 2 days at this point?
Yeah, every day to 2 days is what we would expect to see. We may see more than that or more than that over the next couple of days.
Because of that backlog.
Because of the backlog in testing, and because of the amount of testing is also increasing. So you're screening more people. You're also running a bunch of tests that hadn't been run yet. And so you're going to see this kind of snowball. maybe a week from now, we'll start to see what that curve really looks like. But in the next few days, that curve is going to be artificially steep, and we should all expect that.
We did hear from hospitals when we talked to them today that some are getting those through in about 24 hours. Some are still waiting 5 days or longer. And so as that system catches up, exactly as you're saying.
Yeah, so depending on where the test is being run, who's running it, what kind of test, all those types of things, it may take anywhere from 4 to 6 hours to 4 to 6 days to get that done. And so, everybody's working to make that faster, but right now there's a bit of a backlog. And as that works itself out, we're going to see a little bit of an artificial nature to the curve. So that should just be expected. The next thing I want to mention is that the list of possible symptoms has been expanded really a little bit. So now it's not just fever and pneumonia, as you might have heard before, or severe lower respiratory. Now upper respiratory, cold-like sore throat, that sort of stuff is starting to be considered to be part of it. And we're even hearing some reports that GI symptoms like diarrhea are beginning to be a part of the presenting symptoms for patients too. So temperature by itself is not a reliable inclusion or exclusion. So just because somebody's not febrile does not mean they don't have COVID. And COVID could present in a lot of different ways depending upon your patient. So this is one of the reasons we wanted to talk today, is because as the more we learn about this virus, the more it's important that you understand that this isn't necessarily the flu-like picture that you have in your head. This could look like other things too, and so you really need to take all the precautions to take care of yourself.
So you want to tell your toilet paper joke? He keeps
no,
trying.
I don't want to tell the toilet paper joke. It's no good.
Okay. He keeps working on it. It's getting better.
When I get it perfected, I'll tell it. So in any case, why don't we go through what the expanded guidance is for everybody today, and if Dustin, if you can make sure that that's up on the screen at this point, the second page there. Great.
Okay.
So our goal under all of this at this point is to minimize unprotected exposures. And that means minimize the unprotected exposure to you, minimize the unprotected exposures in the community through social distancing, and minimize the unprotected exposures that we might take home to our families or pass to other healthcare workers or just generally in the community. And so, given the fact that we have these cases in the community now, in our healthcare facilities, in the community at large, and we expect that number to go up significantly over the next few days, we have to take a more proactive approach at this point. We have to protect ourselves, our colleagues, and our patients starting now. We really do.
Absolutely.
So our goal, as you can see, is to minimize unprotected exposures. The first thing that we want you guys to start doing to help with that is to do a standoff assessment. Now, you've probably heard people call this a doorway assessment, a dashboard assessment, a scene size up, whatever you want to call it. What we're looking for is on every patient you come into contact with that you slow down for a second and you maintain that 6 foot at least standoff distance, and you start doing some questioning and assessment to see whether or not you think that person could potentially be a COVID case. And I'll go through in just a second when to suspect a COVID case. But the most important thing is that before you approach within 6 feet of your patient or bystanders on the scene, we want you thinking about this and making sure that you're asking the right questions and looking for the right signs to see if you need to take PPE.
So think about scene safety in terms of these people are going to be really spun up as the community is getting more anxious, as they're watching 24/7 news at home. They've already gotten themselves wound before they're calling us. So you really need to slow that down and think about the anxiety in the community, both in terms of people with weapons when there's scarcity of things, road rage, just the pressure on the community as things get worse. We've got to be thinking safety, and grandma could have a gun, and you got to slow down, and you got to make sure you're not exposing yourself. Same thing that we're talking about here relative to PPE.
Yep. So once you've gotten your standoff, or once you've started your standoff assessment, the things that you want to look for, and this is probably really maybe one of the most important messages of today, is that we really need to adjust the types of people that we suspect possible COVID in. So we're looking now for you to suspect COVID in any patient with the following symptoms, regardless of dispatch notes and regardless of travel history. This virus is in our community, and we have to start assuming that people have it until we get a reasonable thing that maybe they don't. So we want you to suspect COVID-19 in anybody with the following, regardless of dispatch, regardless of travel or contact history. And that is fever, although fever again is not required. Flu-like symptoms, but again, they have other symptoms. Upper respiratory, that's sore throat, cough, congestion, headache. Lower respiratory, that's cough, respiratory difficulty, shortness of breath. And now also GI symptoms, diarrhea, or abdominal discomfort can also be a presenting symptom. So we are starting to hear some cases from over in Broward County and other places in the country where people are showing up to the hospital with diarrhea as their presenting sign.
That's a real wide set of symptoms, you guys. So you really have to be thinking about that and asking all those questions from that doorway on that standoff assessment.
Your machine is muted?
It is.
Okay, we're getting a little bit of an echo, they're saying in the comments. So, okay. There's a little bit of an echo in the room, so that could be it, but we'll try and minimize that. The next thing is, if you're doing your standoff, you're suspecting COVID based upon those things, the very next thing is to protect yourself by donning full PPE anytime you think this could be COVID-19. So that's any patient with respiratory or gastrointestinal infectious symptoms, or really any time you have any suspicion that this could be a COVID-19 related call. So we do not want to rely on what the call taker heard from the person who called them, because we know that people don't always give the accurate information when they call 911. We don't want to rely just on a contact history or a caution note or anything like that. We want you to very proactively take steps to protect yourself. And there is no half measure on PPE right now. If you're putting PPE on, it's the entire ensemble. That is the N95 mask, the face shield or the goggles, the hat, the gown, the gloves, and the shoe covers. And it should really be an all or none kind of a thing. So we're going to standoff assessment, suspect COVID-19, protect ourselves if we have any indication that this could be a COVID. The next thing we want to do is protect the family members of the patients. So effective immediately, patients' families, friends, others, riders are prohibited from being transported to the hospital in the ambulance. This is for everybody's safety, okay? There are a few exceptions to this. If you have a pediatric patient, you can take one parent. If you have somebody who's at home with a caregiver that needs help, you can take one caregiver if they need to help you manage that medical equipment en route to the hospital. But you really should try and ensure that the riders have surgical masks as well.
What do you mean by that with home care and medical devices?
So the most common scenario we might see there is somebody who's on a home vent, and you're on a regular truck rather than a CCT truck, and so you bring that person with you to manage the vent. A trach peg patient who's got feeding pumps, trachs that need to be managed, etc. We know that our home caregivers are expert in dealing with those situations. If we have a lot of kids in the community who have trachs, and mom or whoever their primary caregiver is usually walk around with a spare trach in their purse, and that's the kind of person that would be worthwhile to keep with you on the truck. But again, please try and get a surgical mask on that.
So the home care nurse is there, and she's got a patient on a vent and no PPE, so we can just be no PPE, right?
No. I think one of the important things that we go through this is that we can't rely on other people to do the risk assessment and protect ourselves. You need to yourself be proactive, assess the situation you're walking into before you get up close and personal, and take appropriate precautions if you think there's any reason why this could possibly be COVID.
So if they've got a vent circuit and they've got a HEPA filter on it, that's fine too, right?
So while it's true that the HEPA filters on the exhalation port of your BVM and on the vent filters will filter out the virus, that does not take away the need for PPE, because those things sometimes they pop off, they disconnect. It's not a guarantee. Right. So while that while we do use those filters and intentionally use them to reduce the amount of virus that's coming up into the air, it certainly is not a substitute for PPE.
So, my idea of viral shedding, do they look like Pigpen from the Peanuts comics and Snoopy for the young people?
No. People shed virus in any number of ways. Virus can be in the air you breathe out. If it's airborne, it can be on droplets that you cough or sneeze out. If it's a droplet level, it can be in your tears or your saliva. It can be in your urine or your feces. It could be really anywhere. Viral shedding is a sort of a weird term, but it basically means anytime you're contagious, you're shedding the virus, and then that can be picked up by somebody else. But it could be coming from anywhere, and of course you can't see that. These are way too small. They're not like pollen that you can see landing on your car.
Right.
This is a whole different realm, so there is no way to see this. So you really have to go by what's in front of you and making sure that you're being proactive about your safety.
So really, when you mention allergies, so you've got people that they could be allergies because we've got pollen is up and change of season. It could be seasonal flu. There could even be a mixture, I guess. There's some mixture of, you could have COVID and seasonal flu, or?
Oh, that's a great point. Thanks for bringing that up. So the guidance thus far has been that if you have an alternate explanation, like strep or flu or something like that, that makes COVID less likely. And while that is true, it's unlikely to have both. They're beginning to see signs of some cases where they have one of those other things like, say, strep or regular seasonal influenza and COVID at the same time. So again, this is why it's got to be a very, very broad stance. Any sign of respiratory or GI infection should really be prompting you to take COVID precautions at this point. All right, so we went through standoff, we went through broadly suspecting, protecting yourself, not relying on other people to decide when to protect, but you proactively protecting family members by not doing riders, and now protecting the hospital staff. One of the things we really need to do is try not to spread this from facility to facility, try not to come into the hospital with all of our PPE on and sort of bring those viruses in. We had a call with the hospitals this morning. It was a great call. We're really having some good partnership with them on this. And you're going to start to see more and more, if you're not already seeing it, that they're going to go ahead and have you do that patient handoff right there in the ambulance bay at the front door of the hospital. And that's great. That's perfect. You don't have to go into the hospital. You roll up, you get your patient ready to hand over, you open the ambulance, you give them over. They either put them in a wheelchair or on a stretcher, depending how sick they are, and they take it from there. And then we can do our decon and keep ourselves protected and not have to do that further interface on the inside, not have to go in and then come back out still in PPE to do your decon. So this is just going to be a much smoother process, and from an epidemiologic standpoint, from a prevention standpoint, this is fantastic. We want to prevent that cross-contamination between our crews in and out of the facilities.
Yeah. So kind of working ahead, we want to let you know, but it's not there yet. We want to get to the point where we're not going in and out of nursing homes, we're not going in and out of hospitals, and eventually this will be all calls to the extent that we can. And so we're working on that guidance now. You'll start to see this today and really ramping up pretty quickly of the handoff for possible COVID patients. So make sure you're calling them on the radio and letting them know. They should be meeting you out front. And more we're working on, can we just drop them and go and decon off site? And so we're going to work on continuing to smooth this, trying to make all these straight lines and simple. So as we get busier and busier, we expect to be, it'll be a nice smooth process for us.
Yeah. All right, and so then the final thing is, still back on protecting the hospital staff. If they are going to have you come in the facility, please make sure they're ready for you to go directly to a room. I think you'll see that less and less as this ramps up. They're going to take the patient from you right there at the door. You're not even going to have to enter the hospital. But if you are going to be going in, please make sure that they are ready for you before you come through the doors. Just double check with them that they have a direct line for you right to wherever they need you to be. And then finally, in preparation for offload, we've talked before about minimizing exposure to aerosol generating procedures. That's intubation, that's CPAP, suction, high flow nasal cannula or high flow oxygen. All those things sort of kick up a bunch of virus particles. That's what we mean by aerosolizing procedures. So anytime you're making somebody cough, sputter, suction, get secretions up there into the air, that's an aerosol generating procedure. And we really want you to avoid those if they're not absolutely necessary. If you are going to do those, you really have to be so careful about your PPE and minimize the number of folks that are in that immediate area while you're doing it. And so as we're arriving at the hospital and preparing for offload, anything aerosol generating that can be discontinued, whether that's CPAP, a nebulizer, anything like that, really should be stopped before you're handing the patient off. And speaking of nebulizers, really we should be trying to minimize the use of nebulizers on any patient right now. Sometimes we have to do it, and that's the deal, and we know that, and we take precautions. But if it's possible to defer the neb, let's defer the neb. If you want to consider going some alternate stuff, some EMS systems are actually saying, let's just give them a little bit of epi instead of doing the neb. So what we'd like you to do is be very conscientious about those aerosol generating procedures, and then as you're getting ready for handoff at the hospital, go ahead and just discontinue or pause all those things while we're doing the process of moving the patient out of the ambulance to their screen and then inside the hospital. We don't want to be walking through the hall of a hospital, and they don't want to be walking through the hall of the hospital once we hand the patient over with aerosol coming out of a nebulizer. Right, so really need to be cautious about that. If you have any questions about whether or not we should do the treatment or whatever else, by all means call the online doc. But in general, if things can be deferred, just defer.
Yeah. So Doc, why don't you just walk us through quick, how do you defer or turn off a CPAP once it's established? What's the easiest way to do that?
So you really what you need to do, obviously you can't leave the mask on the patient without the oxygen flowing. So there's a couple options. We have generally the flip up masks. You can undo these two and flip it up. Please turn off the flow as before you open that up. Okay, don't let it open up and spew everywhere. Yeah. So be cautious about this. Understand that if you have high flow air coming anywhere, that's going to be kicking up particles. If you don't have to put somebody on CPAP, don't. If you don't have to give somebody a neb right now, don't. And in point of fact, if we get a lot of people from this with respiratory failure, we may just tell you, go ahead and manage the airway earlier rather than later. Sure. Okay? So we're going to have to see how this goes over the next week or so. We will come back to you as often as we need to keep giving you updated guidance. But for right now, just take the normal common sense steps based upon this information to minimize aerosol and minimize exposure.
Before we move on, we've got a question that ties to symptoms. Is this an and for the symptoms? That has to be all of them, or is it just one of them?
Yeah, so that's a great question, Brian, and the answer is it can be any of them. It is not an and, they're not all required, it's any of the above. A great question, and we'll get into this last part right here, which is asking questions. So online medical control consult is not required for any patient that might be a COVID patient. That's just not sustainable at this point. There's going to be too many of these. Starting now, there's too many of them. So we don't want to discourage you from calling, but you don't have to call on these patients. If you need guidance about limitation or alteration of interventions, like we were just talking about with the NEBs, absolutely. If you need guidance about, what kind of risk stratification am I looking at here, that's fine too. But I really hope that you're taking steps to protect yourself well before you're on the radio with the online doc. And then obviously if you have specific questions or if you're working under a treatment protocol that requires a consult, that's great. So we're not just turning off online, we're just saying the previous guidance on these COVID patients that everybody needs a consult, we're going to turn that off for now. We're always there for you, but we don't need routine consults just for the sake of doing it.
Yeah. So, most of that was about safety, of just slowing down the call to make sure that we had a doc intervening. Now that we're going to be really forward leaning on this PPE, you really should be checking each other. So if one of your if your partner isn't in PPE, check them. If it's the crew coming in the door, it's not PPE, check each other. Remember, let's go back to crew resource management and really stick on that. That's key to everything that we do.
Yeah, I also wanted to put in here the number for the Department of Health Epidemiology desk. There's an expert resource there who can help you with trying to answer questions about exposures or anything else with this. That should be somebody that an agency supervisor or chief or whoever can call if they need questions answered about particulars related to the epidemic and exposures and that kind of stuff. So that's the number there. The documentation and the disposal of waste on the next page are really unchanged, so I'm going to skip over those for the moment.
Oh wait, I don't want to skip.
You don't
over
want to
those.
skip? All right,
those,
go ahead.
Those are important.
Go ahead.
So one thing that we did is Jasmine kept giving us the mom look that we were making things too complicated and too many pages.
I think we've seen a few memes about that.
Yeah,
so keep those memes coming. We appreciate it very much.
So for us, we want to make sure that we're keeping things simple and tight. We really need your help on EPCR. We know EPCR is a drudgery, but there's two things that are key to that. Is anytime that you're taking isolation precautions, get an intervention in the notes of the call or in your intervention line. And then on each person, we want to know what PPE you're in, because that's how we're maintaining our supply. So if you don't document it, we'll run out because we don't know. So we're monitoring inventory, we're monitoring what's going to each station and each department, but that's our real sentinel event that we're pushing to the state and to the feds that we need PPE.
Yeah, for us to be able to be working the back channels to get restock and get enough PPE out there, we really need to know what's being used. So as much as we all really love documentation, this is one of those things that it's super important for us to be able to keep up with.
Kind of a necessary evil. We are going to ask EMS coordinators to really be looking at these charts, and we're preparing some reports to go out to them so that they can monitor your PPE use. And so there should be a one-to-one connection that if you're in PPE, it's listed what you had on you, and there's a there's an isolation precautions taken in the interventions. Otherwise, we don't know how to reconcile that report.
Did you want to talk about disposal of waste or?
Sure, disposal of waste. You want to keep on the red bags currently. You want to put yellow bag. You shouldn't be taking anything out of a red bag. Once it goes into a red bag, it's done. The yellow bags is what you're using for things that need to be deconned more thoroughly after the call. We are working on, like I had said earlier, us moving to a kind of a decon process that is off-site from the hospital. But we have really looked at every possibility, and probably down to one thing that we're working on evaluating now is UV light boxes in order to reuse an N95 mask. And so we're researching how to do that properly. We don't want to just throw caution in the wind and put something out and then go, oh, it didn't work, and we exposed a lot of people. So that may be helping to keep up our supply line. And we are looking at, other lines. There's a couple of questions about PPE that we'll do in the placards.
Yeah, keep throwing the questions up. We'll try to get to all of them before we finish up. And so let's go to the placards real quick and just update those to make sure everybody's seen them and can make sure that they're clear to everybody. So this first placard here is the COVID-19 PPE Special Respiratory Precautions placard. Do we have it up for him?
Yeah.
Excellent.
Good.
So this is simplified way down because, again, it used to have what speed note you see and what that means and what to do. But we don't want you relying just on the speed notes anymore. We want you taking proactive precautions to protect yourself. And so this tells you what goes on my head, what goes on my hands, what goes on my feet and body, and then what are my alternatives if I can't find those. And this is going to be for any patient that we have a PPE dress out for COVID. And so this is it. It's all or nothing. There's no face mask and goggles until I figure it out. No.
Right. Nope.
So all or nothing. We're dressing up. We're being proactive about who we dress up for, how often we dress up. We're really doing that to protect ourselves. And this is our standard right now. If we get to have to change it at some point, we will, but this is what we need you guys to be doing right now.
Sure. The key to this is the alternate PPE options. So there's a question that we're going to continue with the gowns the way that they are and the N95 masks until we run out of them. And when we run out of them, then you're going to go to the half face or full face respirator with a P100, and that's when we move to the TIChem. But it may be mixed. So as we have supplies available, we're going to use the easiest supply for you to utilize. But we're not dressing out differently depending on how sick we think the person is. We're just continuing with the gowns and then moving to the TIChem or the ChemMax or equivalent suit as we run out.
And our hazmat experts have told us that it's a best practice to use a third person who's not gowning up or suiting up to monitor that the PPE is going on and is on properly, and then the doffing is done in the appropriate way so you don't contaminate yourself. So buddy system is fantastic if you have another person, whether it's another clinician or a supervisor or an officer who can be there just to be another set of eyes and do a check, no different than an IMAC check or anything else, just to make sure we're being safe. See something you don't see, it's the old, if you see something, say something. We really got to watch out for each other in this particular time, because we're going to be responsible for our own safety here as we go through this.
We wrote that as the guidance as clinician, office, company officer, or supervisor, because we don't have a supervisor or a company officer on every scene.
And we're not going to as the volume goes up.
As the volume goes up, and so this is, check your buddy to make sure that everybody's safe.
Yeah. All right. Can you put up the second placard there? All right. So we heard that the who does what in what position diagram that we made previously wasn't super easy to follow, so we tried to distill it down after lots of, there's Jasmine giving me her mom face again. We tried to distill it down after lots and lots of versions, and here's the best we've got right now. So we wanted to put this back out to you, hopefully clarify this as best as we can. And as we said before, the goal in all of this is to minimize any unprotected exposures to COVID.
Absolutely.
Again, there's a reminder at the top of this to do your rapid standoff assessment, maintaining that 6 foot or better. All patients, regardless of dispatch information, figure out if there's any fever, GI symptoms, respiratory symptoms, anything that rings your alarm bell for a possible COVID-19, and that is prior to coming within 6 feet of the patient.
Notice how we put 6 feet twice.
Yeah. This is important. This is important. This is no different from like a scene safety size up, so that you don't end up getting shot or something. This is really, really important. We can't just wander in without taking that minute to figure it out. If you don't take that minute to figure out, you could get exposed to something. You could get sick. Your coworkers could get sick. You could take it home to the family, or best case scenario, you could be stuck under quarantine for 2 weeks, which I guarantee that's not a vacation. It's not going to be fun. I promise. It's really going to be unhappy.
I think your family's not going to think it's fun.
Oh, no.
My wife is already doing social distancing with me just because I went to the conference. So,
yeah.
You got an update on the conference? Are we all clear from that?
Well, we're just about there, depending on which days that person was there and we were there. But we're right at the 14-day mark for that exposure. So over the next day or so, that should fall off. I was at the conference on the Wednesday only, so I fell off of that list yesterday. And so we are starting to bypass that. But I'll be honest, we have people in the system who are currently under quarantine for known exposures. And these are not just exposures in the community like at the conference. We do now have crews exposed during a call who are under quarantine. So we really need people to be taking this just as seriously as possible. Okay, this is no joke. This is real. This is here. You've got to protect yourself.
We don't want to make you crazy about it, but just be safe.
You've got to take the regular steps you would take to keep yourself safe. So these are the 4 positions. The first medic on, they're going to put on their full PPE. The first medic that's going to approach the patient, they're going to bring some limited medical equipment to the patient's side. Going to make that contact. They're going to continue with their initial assessment, risk determination, figure out if this person just has a question or a concern, or if they really need to go to the hospital. You're going to make that decision. Once you make that decision, another medic, that's going to be position 3, is going to end up coming in to help you. Position 2, your buddy or partner, as you go to the door, is going to maintain that standoff distance, bring all appropriate medical gear to within striking distance of the patient, but not up close and personal to where you're being contaminated, and be ready to help and hand things should they need. That's a great person to be able to relay something back on the radio, either to dispatch or to an online doc or whoever it is.
Yeah.
And they're sort of as your safety monitor while you're doing that initial assessment in there, but they're not actually coming in, not bringing your monitor and everything else all in there, so everything has to be deconned.
Sure.
If you decide to transport, that other person's going to actually come on. So if it's a Sunstar only call, that second person is going to be usually the fire medic that's going to come in and transport with them. If it's normal operations where the fire medic is first on and then the Sunstar medic comes in as that second person in the number 3 slot to get gowned up and go in. And then those two people are going to basically go through the rest of the call together in their full PPE, and they're going to do whatever treatment needs to be done, load the patient, get the patient to the hospital, offload, hopefully at the door and not inside, and then deal with decon and doffing their PPE.
Sure. So let's talk about a couple of examples. What should be the role for a BLS truck company arriving first?
A BLS truck company arriving first. That's a good question. So if that patient is not extremely sick and needs something right now, you could make a good case that crew might see how far away the medic is. You
want to check the ETA of that other incoming unit. Okay, I'm on an ALS engine and I'm a 4-person crew today. All 4 of us are going in, right, Doc?
No.
Oh, okay. We got to get work through these scenarios, make sure you're all clear.
So I think that this is clear, but because it's this important, it's worth going through again. Only one person is going to the patient's side initially. We need to minimize the number of folks exposed, even with PPE. We're minimizing unprotected exposure and we're minimizing exposure as well. So one person to the patient's side until we've decided to transport or until we need to get more resources in there because we have a significant issue going on that we need to deal with. Yeah. But nobody should be going to the patient's side if we have a suspicion without full PPE on, regardless of what's happening.
So how many people on a code, we go to a real critical patient. Now what are we doing in terms of the number of people and load and go versus staying, 20 minutes in a house or something, 30 minutes?
So that's another really good question, and you're going to have to try and assess the situation as you get there, get the online doc involved in those decision making. The first person, again, to the patient's side must be in full PPE. They're going to have to make that assessment. And then they'll have to call in additional resources as needed, but only as those additional resources are in full PPE. It is, frankly, okay to slow down a little bit here for the sake of protecting ourselves.
Absolutely. And maybe we don't have perfect rotation of 2-minute pit crew CPR, right?
So we may get to that. We're not there yet.
Okay.
The standard of care is still the standard of care.
Okay.
We are in condition yellow in our plan. If we get to condition red, which could happen tomorrow or it could happen next week or 3 weeks from now, then we start really altering the standard of care. And that's when we have to, make those really significant judgment calls and changes.
Good.
The transport vehicle operator, I think it's just worth pointing out, the transport vehicle operator is in a mask and eye protection and not a gown and everything, only because they are up front in the ambulance, nowhere near the patient care compartment. Right. They do not participate in patient care loading or unloading. They do not enter the patient care compartment. They do not get within 6 feet of the patient, and they do not participate in any kind of decon. So that's the only time that you don't need the full ensemble, and the reason for that is that the goggles or face shield and mask are just a double layer of protection. You're up in the front of the ambulance. It should be really well sealed off, but just out of an abundance of caution, we still want you to put on the mask and the face shield.
Right.
Okay.
Those goggles are out there. Don't throw them away. They can be deconned and reused. We do not have an unlimited supply of those, so they should be individual issue and keep them and protect them. And probably the best job in the system now, Sunstar EMT. Hang out in the truck and It's the only exception to your PPE rule too. That's the only time that it's a mask and goggles only.
Only time. And of course, you don't need to take your EPCR into these scenes. You can do the documentation once you get to the hospital. You can be calling out to the person who's doing the standoff to be doing it. You can be, writing stuff down on a piece of tape until you have a chance to do your PCR later.
Yeah.
But
hey, the more stuff you contaminate, the more stuff you have to decontaminate.
Absolutely. All right, so that is the primary points of the updates for today's medical control directive. Again, the overall goal is to minimize unprotected exposures. You want to do your standoff. You want to suspect COVID broadly, protect yourself, protect family members, protect the hospital staff, and ask questions when needed.
Okay. There was a question about printing of EPCR. We'll have to build that into our plan as we're doing less and less inside the hospital. So more to follow on that.
Yeah. So just looking back up through the questions here, I have, when you say full PPE, does that mean the blue gowns or yellow tiebacks? That means the PPE that's listed here in this placard, which is the gown. Now the tiebacks, again, or ChemMax or whatever you call them, will be what we use when we run out of gowns. But as we have gowns, use the gowns.
Yeah.
We covered the all or some symptoms. So when are we using the yellow suits? Okay, I think we got that.
We got that one covered.
Okay.
Go back up to Mark Eggers on the triage about when fire's riding in. So really it's all of the time. Fire medic and Sunstar medic both in the back, and the idea is that we're making this a load and go, and we're keeping that continuity of patient care. So the less time that we're involved, just like a hazmat call, the less exposure that you have, the less time that you're with that patient.
So again, Mark, if it's a pretty well-looking patient, you probably don't need to do a ton of care, but you did have two people gown up and get in full PPE. Usually it's going to be the fire medic who's there first and then the Sunstar medic who comes in. And in order to preserve our supply of PPE and minimize the number of times of on and off, because as you know, and the hazmat guys tell us, every time you don or doff PPE, you put yourself at risk for slipping up a little bit and getting an exposure. So the idea is that no matter if it's a very mild patient or a more severe patient, those two medics are the primary folks that are in PPE and doing the care from wherever we got the patient all the way to when we transfer care at the hospital. Sure. And then those two folks together do the decon and doff.
Yeah. Chiefs can keep track of increased fuel usage and out of service times because it's going to be a Category B expense. There'll be a lot of ride-in. All of these are ride-in and unit following.
Yeah. Savadra says, any issues with isolation room availability so far? No, we haven't seen that. The hospitals are all working very hard on their flows. I'm actually fairly impressed so far with how our hospitals have done. I know a lot of them you're starting to see them set up tents and alternate pathways. It's definitely been a best practice that they have a branch point right at the entrance, and you have one pathway for anybody who might be and another pathway for people who definitely aren't.
Sure.
And so we've seen them doing that, and we've seen them augmenting their resources. So Josh, no, we haven't seen any issues with that yet.
Not yet. But I think we need to kind of be eyes wide open that there are not a lot of unfilled beds in hospitals in America, and certainly here. They're 80% capacity most days during this part of the year. We have a limit in the number of ICU beds and CCU beds, and there's a limit in the number of ventilators. We did hear that they're converting areas where they've got to change out the air conditioning system to be negative pressure and isolation rooms. So
we're seeing more and more. We're seeing entire wards being transferred to isolation status wards. It's not an easy thing to do, and the rooms each are often still negative pressure. But in a real pinch, they can make the entire unit negative pressure. And if you know already that everybody in there has COVID. So you can do what's called cohorting a bunch of patients in there, where if everybody, if you have a single unit that exhausts through a filter to the outside of the hospital, you can put a bunch of people in there who all have the same virus, and then it's sort of a moot point about keeping them separate from each other. So we're starting to see the hospitals take some really good action on that, and I think you'll see a lot more of that in days to come.
Sure.
The big thing I think that we're going to see, and this is what I've heard, I've spoken with some of the ER docs up in New York around New Rochelle. I've spoken with some doctors from the West Coast that have already seen some of this stuff. and even some been in touch with some folks from Italy who are in the middle of it right now. And right now we are seeing the beginning to trickle of patients into the hospital. There are ones and twos and generally single digits at our facilities. And what we are told from the people that are ahead of the curve on this with us, that are 2, 3, 4, 5 weeks ahead of us, is that from now, when we start to see that initial trigger or trickle of patients, that about 2 weeks from now, we should expect to see a large number of really sick respiratory failure pneumonia patients. And so we really are working hard behind the scenes to ramp up ventilator capacity, room capacity, hospital capacity, all of those things in preparation for what we expect to be a big surge of respiratory failure patients over the next 2 to 3 weeks.
Absolutely. We've got an all y'all, I call it, an all hands face-to-face meeting, even though it's a bit risky, just because we've got to have this plan built and correct, and it's our condition red plan. So as the community resources go to be unavailable, whether that's hospital beds or the ability to drop off patients, or even the impact on us, either workforce or availability of units just because of volume, that's going to push us into that condition red level. We're building out that plan tomorrow, and the idea is that we're 2 weeks ahead on when we think this is really going to go. I think once we turn that on, we don't turn it off till we're done, and it's going to have things like alternate destinations to not load up the hospitals. Probably a paramedic induced stay at home and call the Department of Health.
Yeah, actually, let me pause you on that one for a second.
Yeah, go ahead.
Kenny, the answer is yes. A paramedic triage protocol, sometimes also referred to as a paramedic initiated refusal protocol, is in the works. It's not ready yet. We haven't turned it on yet. The state actually put out a sample version of that. We're making it a little better, I hope, here locally, and we're actually doing it in some ways in partnership with the medical directors from Hillsborough County and City of Tampa, so that we're all kind of doing the same thing across the region.
Doc has built himself a little network here, so we now have folks that are affiliated with Dr. Jameson in Tampa and Hillsborough and Sarasota, and all of them. They've been the state has really looked to help build out this protocol that started as kind of a real loose draft.
Yeah, so the answer, Kenny, is yes, it's coming. We're not quite there yet, but do anticipate that when things get really bad, for those mild patients who meet certain criteria, you would be able to do a paramedic-initiated triage out at home, kind of a protocol.
Surgical mask?
Wait, sorry, there's a follow-up question on that one real quick. I don't know who P-05 is, but yeah, we saw that one. We're going to be following it up. That was where a hospital called a patient who's at home with little or no symptoms and told him he needed to come back to the hospital because he had contact with a confirmed case. So do not be surprised if people are calling 911, as people do, for somebody called me and told me I have to go to the hospital, and when I need to go to the hospital, I call 911. Don't be surprised, and make sure that you're taking appropriate precautions and protecting yourself. We will follow up that particular case with that particular hospital and make sure that that's not part of their written plan or their guidance to their folks. This is the world we live in, and this is the job we do, so don't be surprised, and make sure that you're taking appropriate precautions.
We're going to see all kinds of crazy before we're done. So, for example, we had a multiple COVID-19 patient situation reported at a nursing home, and it turned out after we looked at data and hadn't been there and had an EMS chief check it out and found out it was a CNA that was manager supervisor. So we're going to have all kinds of crazy. Also, a lot of public information coming out in random ways. So, we're just going to have to deal with it as it comes.
Yeah. So, let's see. Mark, with a follow-up question on the surgical mask for family or other healthcare home health folks that are riding in with us. Yeah, so there is one in the PPE kit. We are working very hard to get you other surgical masks. It is limited right now. We're doing the best we can to get those for you. So stay tuned. We're trying. Hopefully, if they're like a home healthcare person or something, they might have their own already. But we are working on that. All right, I see another one up here.
Well, talking about things that we're working on while you're scrolling through it is thermometers. So not the best. We're sending you oral thermometers with covers just to get some capability out there. Those will ship tomorrow. And then we are working on the infrared thermometers so that we can be the 6-foot standoff. And we're working on the procurement of those.
Well, those are actually not for patient use at this point.
Right. Yeah. Oh, sorry. They're for our use.
Right. Right. So
yeah.
just to be clear,
Yeah.
we are not taking temperatures on patients.
Yeah.
Well,
we're still 6-foot standoff from each other when we come to work, right?
Yeah. So because fever is not a reliable rule in or rule out, there's no point in using that as a discrimination for who we should be taking any temperature on to say, oh, well, if they have a temperature, I should wear PPE, and if they don't, I shouldn't. That's not reliable,
yeah.
So we can't use it for that. So the temperature really doesn't actually help us with the patient care so much. Temperature really will help us to monitor ourselves and make sure that we're not finding any symptoms in ourselves, and also to make sure to screen each other at the start of our shifts. I know you've had some of the healthcare facilities wanted to take your temperatures. Look, that's an executive order from the governor and from the people that regulate them. So we're working on the best way through that. If they're just looking to put the red dot on you or whatever else at this point, it may be easiest just to go along with it. They're being asked and required essentially by law to do that, so don't be surprised.
It's probably a whole political meltdown if you refuse to, so we hadn't gotten a chance to talk about it, but maybe at some point our thermometers, we could take our own temperature and show, hey, we're not feverish. Jacaranda Manor would like us to use their oral thermometers. I'm not sure any of us are going to be into doing that.
Yeah, so I think what we would like to see eventually is that, similar to the hospitals offloading the patients from us in the ambulance bay, we would like to see as much as possible for our other healthcare facilities to actually bring the patients out front to us so that we're not in and out of those facilities as well. Now, don't misunderstand, this is not an expectation or a policy right now, but it is something that we're actively talking with them about the best way around that. So, do the best we can with it. The thermometers that you're going to see again are more for screening ourselves and looking for symptoms in ourselves, not for patient use.
Not patient use. Yeah. And that guidance probably won't change. We won't be doing. There's no real value in. We've talked about that several times over the years. So taking the temperature of a patient really doesn't help us much.
Yeah. Okay. I've heard a couple questions now about what should you do if you recognize symptoms in yourself. So, number one, don't come to work. Seriously, I know that sounds kind of blunt, but if you get regular influenza or strep throat or something like that, and you come spread it to your colleagues at work, everybody that's sick is going to have to be out until that's proven not to be COVID. And so you could cause people to be out for weeks. And we just can't afford that in our workforce right now. So if you have a cold, if you have a sore throat, if you're not feeling well, if you are sick, you should not come to work and expose your coworkers to that. We as a system can't allow that right now. It's just we're going to be strained very much, I believe, over the next few weeks, and we need to keep our folks in the game just as much as possible. If you are concerned that you actually have COVID, I would suggest that you call your primary care provider or the health department hotline number that they have out there and see whether they want to refer you for testing. Testing is ramping up around the community. A lot of places now, with your primary care doctor's prescription, you can drive through in your car and get a test. So the number one thing is, if you're sick for any reason, don't come to work. If you think you have COVID, please work with your primary care physician or whoever your normal access to healthcare is to get that looked into. Okay, next one.
Telehealth, big thing.
Yeah, telehealth's going to be big as we go through this. Telehealth's, let's see. Will you be making any public announcements to educate them on our process when they call 911?
Yeah.
So, marketing communications has actually already put out information to not be surprised if you see paramedics and EMS folks in full PPE. It does not mean that there's some big thing going on. It means we're taking proper precautions. That messaging has already gone out. And the messaging about the questions they might get asked by a 911 call taker has already gone out. Both of those were last week, I believe, Alan.
Yeah, absolutely. And, when we get to Condition Red, we're working, Department of Health locally has been very, very supportive. Dr. Cho, Gail Guidish, all of their staff been incredible with us. We're going to have a linked message so that the number that we call will be the Department of Health number. We refer people to their website. The policy that we put out will be blessed by Department of Health. And then we'll put, there is a joint information center that's running between DOH public information people and county information people. And they're working back with your city, fire district, Sunstar, everybody's PIO.
All right. Somebody from, is that Bobby D41C?
Hey, District 41.
I think that's District 41C shift maybe. Can dispatch tell people with no symptoms who have been in contact with confirmed COVID-19 to drive themselves to the hospital instead of sending a Sunstar fire unit?
Yeah, buddy.
Yeah. So those protocols are in process of being worked up as well.
Yeah.
And don't be surprised if you see something like that over the next week and a half.
Yeah. So that's really going to be in that package that we work on tomorrow. We really want to have that buttoned up, by Monday, start to vet that through, and go from there.
Yeah, and we may even also be doing shunting 911 callers who are calling just to ask questions about it to another information source as well.
Yeah.
All right. I didn't see any that we didn't get to, but if we missed your question, repost now, or if you have any other last questions, I think we're going to wrap this up pretty soon because we don't want to make it too terribly long, and we might do another quick bullet point thing at the end if you want, but we'll see. Give you just a couple of seconds since we have a delay to put your stuff up. All right, so thank you, sir. A particular fire chief has said, is loss of facial hair a sign of COVID-19? And the answer is yes, it is. This is the first time I have been beardless since high school. So you are looking at a COVID-19 beard loss. It's a very, very sad day. It's probably a good excuse to just wear a mask.
Just wear it all the time.
At all times, so you all can actually recognize me.
Yep, see now you look
and
normal.
not see that craziness, but yes, Chief, that is a sign of COVID.
I think your mom said you had a beard when you were about 10 or 11.
Probably. I had hair then too, but only a little bit. All right.
Let's see.
I don't see any further questions, and we've been stalling for long enough, so I think we'll go ahead and wrap it up there. I also think that we will try to continue to do these on a regular basis, at least once or twice a week, as we go through this, to bring you as up-to-date and latest information as we can. And hopefully these are helpful to you in getting the information that you need to keep yourself safe. So again, our big push this time is minimizing unprotected exposures. That's following the appropriate PPE. That's minimizing the number of folks to the patient side, following the roles of who does what. It's like our pit crew for COVID, and making sure you do your standoff, you suspect COVID widely, you protect yourself, the family members, the hospital staff, and you're asking the appropriate questions when need be.
Yeah. So all prior guidance, pull it down off the wall, pull it off the truck, throw it in the trash. This is the only guidance that's out there. Make sure that those placards get printed and up in the stations and on trucks, and make sure that you please really read this, all about your safety, patient safety.
Yeah. Okay, so the chief said no more soup for you. Very good. And Mike, you can send all those memes to me, and we will try to share them on the next video. You're welcome.
Only of Jasmine now, not of us.
No, I vote for Craig too on the memes. Come on, fire away. I know they do them for me already. What is it? What is it they call me? Beef whiskey, I think. Yeah, you're called out. I know who you are. So with that, you guys, please stay safe.
Everybody uses my name in vain, so just say Craig Harris said that we have to do this. If people are giving you a hard time, you know.
Yep. Okay, take care, everybody. Please let us know what we can do to help keep you safe through this.
Yeah. Check your Target solutions.